Okay, during our session, Dr. Sanjay, coming from Nepal, is doing live surgery, and as soon we get information from the operating theater, we are connecting to the operating theater and showing you live surgery PCNL. And meanwhile, I would like to ask Dr. Pal from India to give us a talk. And this talk is entitled Standard PCNL is still the ideal approach with safer and more effective outcome. Please, Dr. Pal.
Thank you, Dr. Abdul Fadl and other members of scientific committee to have given me this second opportunity. Thank you very much. It is 11:59, so good afternoon to everyone present here. It is a sort of debate whether standard PCNL is the ideal approach or mini PCNL. I will be fighting for standard PCNL, and our dear friend Swin is going to tell us about mini PCNL. Let us see who is able to convince all of you. So I bring you greetings from India, and we are going to discuss management of large stones with PNL. Which method and why? I am going to talk about standard PCNL because I feel it is still the ideal approach with safer and more effective outcome for larger stones. I will not stop here. In last 36 years, Swin, I have not found any technique which has stood the test of time and established a clear superiority over standard PCNL for large stones. Many techniques have come and gone, but standard PCNL is still there, standing like a rock. So I will add, this is the ideal solution for long-term stone-free status also, because we are looking for a long-term stone-free status, and standard PCNL gives you that also. Because all other modalities, they depend upon further fragmentation, finer fragmentation, and dusting. Like my good friend Chandra was mentioning about face powder. I don't like it at all. All other modalities are more time consuming. Zheng has clearly shown in his slides that the only problem is these are long, take long time. So long time is not good for PCNL. And they lead to higher intrapelvic pressures for prolonged time, which will be causing a life-threatening sepsis. All other modalities have compromised visibility, small scope size, within pelvic ileal system leading to poor stone clearance. Then why to go for that? All other modalities are more expensive. The cheapest is standard PCNL. And when you are going to strain yourself for a longer time, your operation theater, everything is strained up, as well as you are also tired. Then why to go for that? Let us discuss about fragmentation. Why do I hate it? What is the basic difference between a standard versus miniaturized PCNL? It is only the smaller track size. And when the track is smaller and you have to remove the same bulk from the smaller track, definitely, logically, you are going to have longer duration. Understand fragmentation. Every stone has 3 dimensions: length, breadth, and width. So 20 millimeter stone, don't think that it will have only 10 fragments of 2 millimeter. No. Any 20 millimeter stone is actually 20 millimeter by 20 millimeter by 20 millimeter. Just take it as generalized. And once there is a 20 millimeter stone in lengthwise, it will have 10 fragments of 2 millimeter. Breadthwise, it will have again 10 fragments of 2 millimeter. And in depth also, it will have 10 fragments of 2 millimeter. So the number of stone fragments of 2 millimeter will be 1000. Not only 10 fragments, 10 into 10 into 10. And you have to remove all these fragments from half the size of your implant sheath. Now consider a 21 millimeter stone, which is starting as a larger stone, and you have to remove it through the 24 French sheath. So this will have, one 24 French sheath has a 8 millimeter diameter. So stone you can remove is 7 millimeter, not bigger than that. So it will be having 3 fragments in length, 3 fragments in breadth, and 3 fragments in height. So there will be 3 into 3 into 3, only 27 fragments you have to remove. Same stone, if you want to remove through the 12 French sheath, which has a diameter of 4 millimeter, so the stone size cannot be more than 3 millimeter. So you will have 343 fragments of 3 millimeter. See the difference. 12 times more fragment to be removed from the half size of the track. It doesn't need a huge study of multi-center study and to prove that it is going to take long time. And if the stone is 42 millimeter and you have to remove by 24 French sheath, you have to remove only 216 fragments. As compared, there will be 2744 fragments if you want to take it out from 12 French sheath. How is it possible? Fragmentation increases the burden of removal, evacuation, suction, whatever you say, you have to remove every fragment so that there is no recurrence. Even one fragment remaining behind, it will cause recurrence. So it is going to take long time, and formation of stone dust will be there, face powder of our friend. It will go to the inaccessible calyces with the rapid irrigation, and that will be the nidus for the next stone. So there is higher probability of residual fragments and recurrences, which is definite. So we are all aware of story of fragmentation technique. We have suffered ESWL. Kamil Sarika is not here, so I can use that word. So we have suffered ESWL. See, such a nice stone. This is the IVU, which could have been removed easily with PCNL in about 1.5 hours. Nicely fragmented, with DJ stent, without DJ stent, waiting. And after 32 sessions of ESWL, see what has happened to the kidney. Have we made it any better? Any fragmentation technique? That is what they are doing. And ultimately, this patient required a PCNL and ureteroscopy, 3 hours, and all the fragments were removed. So we should analyze and learn from our mistakes of fragmentation to advance further, rather than going on repeating the same mistakes and calling, oops, I have spilled the beans again. Don't do it. Coming to more time consuming. Definitely, when you are removing so many stones, it is going to be more time consuming, and it will increase the chances of sepsis and unrecognized hemorrhage. We are all surgeons, we are extrovert, we are heroes, we think we are supreme, we do very good things, and nothing is lost. But if you see the first part, if you remove a 1 centimeter stone intact through the 30 French track, this video is lasting only 8 seconds. In 8 seconds, through 30 French track, 1 centimeter stone was removed. While if you make a limited larger fragments, this much can also be removed in maybe about 20 minutes, but so many multiple small fragments cannot be removed so easily. All studies, comparative studies, have shown mini PCNL takes longer operating time. And if you see the sepsis, all papers of predictive factors of fever and sepsis, one of the feature is prolonged operative time. This is a study which, again, there is a post-percutaneous nephrolithotomy, which were the patients who went into septic and severe hemorrhage when there was a long operative time and severe hemorrhage. So why to go for such a technique and subject for a longer operative time? Regarding unrecognized hemorrhage, all of us, if we see our effluent fluid of this color, do we ever bother? We tell our anesthetist, oh, hardly there is any bleeding. See, nothing is there. But actually our study has shown that when we put this at irrigation fluid at 60 to 90 centimeter, we are using 350 ml of saline irrigation every minute. And when you add 10 ml of blood in 350 ml of saline, this is the color. 10 ml per minute, we don't bother. We call it unrecognized. And when this continues for 60 minutes, there is 600 ml of blood loss. And if your surgery continues for 2 hours, you are losing 1200 ml of blood. So this is not, this goes unrecognized. This is when you mix 10 ml of blood in 350 ml of saline. This is the color when you add 15 ml per minute loss, and this is the picture when you take 20 ml blood loss per minute. We hardly bother about it. So how to monitor the blood loss when you are starting PCNL? This is just a tip. Neurosurgeon should see the time, exact time of starting, limited surgery to less than 60 minutes or maximum by 120 minutes if the patient is fit. Also, the pulse rate should be seen on the monitor, not by anesthetist, by the surgeon. When there is a tachycardia of more than 10 or 15 beats per minute, definitely significant blood loss has taken place. That is the time when you should stop. So if you have started with 60 pulse rate, as soon as the pulse rate goes to 70 or 80, immediately stop your procedure. Significant blood loss has already taken place. Now, when there is a miniaturized instruments, there is rise of intrapelvic pressure. And this is what is causing death in PCNL. 99% of deaths in PCNL, intraoperative complication, it is because of sepsis, which is not under our control. We have to depend upon antibiotics. So to reduce the intrapelvic pressure, we should we should have a good difference between the size of implant sheath and size of your nephroscope, so that there is a good efflux continuing. A standard PCNL conventionally requires gravity dependent irrigation system. Irrigation fluid passes rapidly through a wider channel of water irrigation, and there is a wider channel of egress, so clear visibility is maintained inside, and intrapelvic pressure is less. Intrapelvic, while other techniques like mini PCNL, sometimes they depend upon these pumps being used. They depend upon faster irrigation. So these will increase the intrapelvic pressure and chances of sepsis. Any pressure which goes beyond 60 centimeters of water can cause pharyngeal rupture, and then there will be pylolymphatic, pylovenous, pylotubular, pylointerstitial and pylosinus absorption. And if there is little bit of infection inside the stone, which is in 30% of cases, then there are chances of sepsis and fever. So generation of high intrapelvic pressure takes place in miniaturized techniques, not in standard PCNL. And they cause more damage and chances of death. Now once there is a small irrigation, small optics, there will be compromised visibility within the pelvic ileal system, leading to poor stone clearance. Some stones will not be seen. You will not be able to see them clearly. Also, this standard PCNL, they have rod lens system in optics as compared to the fiber optic systems when there is a 12 French nephroscope or smaller. So rod lens system always has a better view, better visibility. Mini nephroscopes are based on fiber optic system. So vision is not as crystal clear as you see with standard nephroscope. Stone recurrence rates, if you see after fragmentation procedures, this is a nice paper which clearly shows recurrence rate of 16% in first 6 months after RIRS. 16%. And when the stones were removed by PCNL, new stone formation 22.2% after ESWL within a year, as compared to 4.2% after PCNL in 1 year. In both these, stones were completely removed. And after 1 year when they studied, after ESWL, there were 22.2% recurrence of stone as compared to 4.2 in cases of PCNL. And the conclusion was higher recurrences may be caused by microscopic sand particles migrating to dependent calyces, because recurrences were more common in the inferior pole and in anterior calyces, which are dependent calyces during procedure, where the recurrence takes place after ESW and after RIRS. Lastly, there is no confusion. You have to depend upon so many other things. You have to have xenon light source. You have to have a flexible ureterorinoscope. They cost money. You have to have lasers when you are using miniaturized techniques. And who is going to pay? It is the patient who is going to pay. So they are more expensive. Why to go for that? Additional expenditure on the hospital or solo urologist for introducing fashionable techniques. And when you do very quickly and you come out smiling because just 1 hour of surgery, you are happy. Your nurse also goes happy. She is comfortable. She is enjoying life. And when you reach home, you can have time for your family. And when the children go to sleep, you can have fun. After mini PCNL, when the person comes out after removing 4 centimeter stone, he is like this. And then he is saying, oh, I have fragmented the stone well, and inshallah, the God will take care of the remaining stones. Most likely, perhaps, all the stones will come out. You should have good confidence. This is urologist after miniaturized techniques. Why to go for that? There is no need to get confused. Standard PCNL 24 to 30 French is the best modality for larger renal calculi. It achieves highest possible stone-free state, minimal morbidity, shortest treatment time, lowest cost, minimal recurrence term rates. So this is a long-term solution. And standard PCNL is the best option because it is well established since last 40 years. It has not been replaced. Highest stone-free rates in terms of no residual fragments. Lowest incidence of recurrence, faster irrigation, wider telescope assures clear vision, wider outlet assures no rise of intrapelvic pressure, very safe, very cost-effective, minimal complications and morbidity, minimum strain on the urologist and OR facility of your busy hospital. So there is no better way. Please learn PCNL. Don't hesitate in doing a track of 24 to 30 French and remove your stones and be happy. Thank you very much.
It's okay. So we will continue the challenge between you and the
Sin.
lab. So we will see the presentation, and after we can continue to discuss this.
Sure, sir.